All right, so I'm Lori. I'm the director of our very own genetic counseling training program, and I've given this lecture for several years now. I make it, this is the first time I guess I've chosen to speak during ACMG, and usually this is a very interactive session, and it's built that way, so a lot of pressure on you guys. Or we'll just fly through and we'll end early. It's not going to be very exciting if people aren't going to chat. So a couple of so my topic is supposed to be to help you prepare for the genetic counseling kinds of questions that might come up on your exam. I took the general genetics exam 20 years ago, and it's probably similar in terms of the kinds of questions they ask, although of course lots has changed. But that is my only expertise with regard to thinking about the kinds of questions in particular. I don't have any formal insight into exactly what they're going to ask. I've seen the outline that you've all seen, and we'll go through that, and I'm going to try to give you some insight into thinking about how you might think through the kinds of questions I think they're likely to ask you, but your guess is as good as mine.
I remember from the insert seeing some bizarre questions.
Yes, and so the genetic counselors now take a separate exam that's managed by somebody totally different, and my students who spend a lot of time talking about psychosocial issues and genetic counseling and have lots of training always say this is the hardest part of their exam, sort of the psychosocial kinds of questions. They're just, as you can imagine, they're very subjective in many instances, and it's hard to sort of suss out. So we're going to talk through today a lot of strategies for how you try to think through a question, and most of my talk is example questions that I've created. I do, as a disclaimer, I am on the board of directors for the ABGC, which is the credentialing body for the certifying body for genetic counselors, but because I'm a program director, I'm not allowed to sit on the certification exam committee, so I don't actually have any insights even into what their questions look like. I just know a bit about the item writer process and the way they kind of go about creating questions. So these are questions I created. They may or may not reflect what's actually on your exam, but they should at least come close in terms of content and giving you some ideas about strategy. So genetic counseling, as I teach it to our students, follows this sort of just definition, and all of what's in this definition is not going to be what is constituted in the 5% of genetic counseling questions on your exam. A lot of what we do is also what you do in terms of risk interpretation, collecting family medical history, interpreting that. That's not the genetic counseling questions on the exam. That's all happening in other elements of the questions. So today we're mostly focusing on the counseling to promote informed choices and adaptation to risk. And to some extent also about how you go about education. So those two components. And if you've looked recently at your board exam outline, these are the elements that they say are in the genetic counseling section. So psychosocial issues, legal issues, specifically confidentiality, ethical issues, and then this other, I don't know what's in other, but there will be other kinds of questions. And we're going to go through some examples of what each of these might be, and then again, as I said, some example questions to sort of get a feel for how you might begin approaching these. So the psychosocial issues bucket, in my mind, sort of, it's large, but it includes sort of three main categories. So one would be the psychological impact of diagnosis in an individual or family. So recognizing in context what the possible psychological ramifications might be and being able to answer questions about those. So these are some examples of the kinds of scenarios they might present you with. So they might say there's a pregnant woman distraught because of an abnormal ultrasound finding, and how would you manage her case given her distress? They might say there's a person who's just learning that his father has Huntington's disease. How do you think about what are the possible psychological impacts of that? A mother struggling to avoid disclosing her son's Marfan diagnosis to him and others. So thinking about the issue of disclosure and how that affects people's emotions, and also how that affects their decision-making processes. Siblings that have different test results and how that processes out in terms of family dynamics. So these are the kinds of examples that might come up in terms of the psychological impact. There's also another big bucket around decision-making, which also falls into the psychosocial issues. And this would include examples of thinking about deciding whether to undergo testing, thinking about a client who's declined testing that you might expect them to take, and how do you help counsel in those sorts of scenarios, thinking about couples who've got screening results and how you counsel them with abnormal screening results. So, and again, thinking about how you facilitate decision-making, and there are a whole cast of questions that people might ask in that bucket. And then the final bucket is this bucket of risk communication under psychosocial issues. So thinking about what are the characteristics of a client that might affect how they perceive risk, how you should approach the communication process with them. So for instance, they might present you with a patient they say has low literacy skills, and think about how you should approach educating that patient. Or they might tell you that somebody is an unaffected sibling of a child and has thinks these are at very high risk. They have very high risk perception in regard to what the actual objective risk might be and how you think about the difference between risk perception and objective risk. Or they might tell you that there's a second cousin couple that have been told they have an elevated risk, and how do you begin to help them consider what that risk means to them. So there could be a variety of different, again, these questions are not going to be about what's the actual risk, but they may be about how do you communicate that risk. And then finally, fourth bucket, cultural issues. So multicultural counseling issues come up, and these will be embedded in the context of many questions they may ask you, and trying to ask you to sort of think about what is it about this particular context that may change your approach to the patient. So you may be given a specific area of the world to think about, and think about what might be the reasons behind what's going on, and more likely they're going to ask you what are the next best approaches. So this is what's happening, given what you know about the context, what might you do next? And so they're often going to present you with 4 or 5 different choices and say, which one do you think is the best next approach? And that's where the subjectivity comes into play. What I want you to get a feel for in going through the examples we go through today is thinking about what are the clues that you're looking for in the stem of the question that give you a sense of what might be what's this question trying to ask me? What are they, so that you can begin to sort of analyze the question.
Sorry, you can go to that later on maybe, but the first example, what is it pointing towards?
Yeah, so in this one, they're trying to get you to recognize that, so from a Western culture, we might think that a person who's not participating in the session, we might assume that that has something to do with their feelings about this particular context that they're being counseled in, when in fact, from non-Western cultures, there may just be a cultural phenomenon in which women tend to not speak up as much in a session, and so you may not want to read into what that means as much. The cultural questions are always a little tricky because in a real patient interaction, I would always tell my students, you should never make assumptions.
Right.
You should get to know the exact patient in front of you and not be caught up in all of the things that, right, but they're asking you to make assumptions and try to get a sense of, this is why I think my students struggle with these questions often, is because they want to say it's individual. It matters on who this person is, and I can't choose among these because it depends. It depends. And what you have to do when you answer the questions is say, well, yes, it may depend on the person, but what is the thing they're likely trying to get me to say here? So another scenario might be one about thinking about different beliefs around religiosity and the role of spirituality and religion, and thinking about how you help incorporate that into a session. So again, these are often not going to have right or wrong answers, but they're going to be sort of better or worse, which is the better or worse approach. So those are the psychological ones, and we'll go through a whole bunch of examples of psychosocial questions. Those I think are the hardest because they're the most subjective. So the next group, the legal issues and the ethical issues, those usually are questions that are built around a specific principle, a practice guideline or a specific ethical principle they're trying to get you to recognize. And so it's often easier if you can recognize what it is they're trying to get you to answer, figure out what the right answer is. But these might be questions around thinking about what to tell somebody about pre-symptomatic testing, or how about potential non-disclosure in a family, what is our duty to warn? I guarantee there'll be some questions about duty to warn, and do you have what's your role in trying to help family members to know about their risks, and does that change depending on the context of the session? There might be questions about genetic discrimination in this bucket, and then also questions around thinking about family communication and what's appropriate in terms of trying to get people's information in order to inform, and where are the lines that get drawn when somebody doesn't want to give that information. It might be informative to somebody else. And again, a lot of these are going to be about family communication and privacy and confidentiality. And they said that would be the biggest legal issue. Confidentiality was the big subgroup in that group. And then ethical issues, they're going to ask questions likely to get you to think about the balance between the various ethical principles, respect for persons, beneficence, non-maleficence, and justice. And so some of these questions will be written in such a way that it might be obvious. Others are going to ask you to be balancing a couple of different principles and thinking about how, given the the tug between the different principles. What do you think is the right approach? They shouldn't, I would hope, not put you in a position where you choose between two principles, but what they're trying to get you to do, I think, most often is that recognize that there are two different elements to the case that you should be thinking about, and propose, given those, how you begin to work through. So often the response options will be things like seek outside help, or try to bring in a person to help encourage a discussion around this issue, as opposed to the right answer being, well, of course, you just support autonomy. So they're trying to get you to recognize that that they're complicated. They give you specific questions around trying to recognize when somebody's cognitively able to make a decision, who has autonomy to make certain decisions. How do you manage when you're trying to support the autonomy of two different people who have very different opinions? Lots of questions potentially around informed consent, and informed consent and testing in minors in particular, knowing your practice guidelines there, and then handling disclosures of non-paternity. All of these would be sort of ethical issues that might come up. So a couple seeking exome sequencing for a child where you think there might not be adequate clinical justification. So this comes back to the sort of autonomy versus justice. Is it appropriate use of resources versus trying to support what a patient particularly wants? And then in the ethical issues bucket as well, I would expect some questions around human subjects research protection in this regard as well. So thinking about de-identification and re-identification of DNA-based data and how that fits into informed consent, thinking about return of results in a research setting, and thinking about who gives informed consent assent and how you weigh parents versus children's consent and assent, and then issues versus broad versus specific consent in studies. So I think these questions are all relatively fair game data sharing. So overall, as I said, what you're trying to pick up here is how to pick the best response and what's your strategy in tests. So I would say the first thing to do when you rate a question is to consider the circumstances they're providing you. They're giving you details usually for reasons in these questions. Who's the patient? What is your agenda with that patient? And what's the context in which? So just keeping those things in mind before you start reading the response options. Because you don't want to get pulled into a response that feels right before you've actually thought through the case yourself. Because it's often tempting to just pick one that just seems like it's jumping off the page, and often they put some examples in there that are meant to throw you. When in doubt, even though I said that there's often a pull between different ethical principles, often they're trying to get you to think about maximizing patient autonomy and choice. So when in doubt, that is often a reasonable way to go, is to think that which is the option here that helps me maximize patient choice the most, and minimizing directiveness and paternalism. So that's one of the principles they're going to be testing lots. Avoid any choices, so start marking off choices that seem like they're obvious no's. Avoid those that are going to infer personal bias on your part, that it's clear this option is implying an assumption that you're making as a provider. Get rid of that one. Often the answer is going to be assess or seek more information. So if you're trying to pick the best option, the one that says get to know your patient better, figure out what they need more, is probably the best, is often going to be the best answer. So assessment is a good go-to. And when faced with several less than ideal options, you're just picking the one that's least bad. Because again, thinking about this is a multiple choice question that's trying to represent something that's much more complex than you can actually represent in real life. And usually you should be able to get rid of one or two just off the bat, looking at them and saying, I'm sure it's not this one and this one, here's why it's not, how do I choose between the two that are left or the three that are left. Okay, so given that broad, so we're going to go through a whole bunch of sample questions. And what I've done is I've given you a question, I've given you the response options in the next page, and I'm not going to give you the answer. We're going to talk it through, and then I'll give you the answer. So first question, you've got a 30-year-old software engineer, just learned that his father, who's been seeing a neurologist for several years, has been diagnosed with Huntington's disease. This is his first clinic visit with you. What's the least appropriate discussion or plan? Well, you look at those notes. These are the things that they're going to give you. What's the least thing? So maybe, Erin.
Work harder, right?
Yeah. So why do you think that? Right. Right. Well, and there is a protocol, although I will say that the very classic Huntington's protocol, people are starting to modify it quite a lot now. So the old classic protocol was you have an initial visit where you go through what the test is going to entail. You have a mental health assessment with a psychologist. You don't get testing on that day. You have to go home and think about it. You come back to have a second meeting with the genetic counselor. Then you have your blood drawn. Then you come back for in-person results disclosure, and then you have follow-up in person. That has been condensed a bit in recent years. So people are actually often in that first visit where you've got a genetic counseling visit and a mental health assessment with a psychologist, allowing for a blood draw to happen on that first visit. But I would say you really want that assessment to include a lot of counseling and a lot of opportunity for people to realize this. There's no urgency to this test, and it shouldn't be something that's done on an urgent basis. So given the way they've outlined this, that this is such an early part of his process, it's not saying you would never order testing in that first visit, but it would certainly be of the options here the least good. Particularly keeping in mind that, I don't know whether you guys know the statistics, but fewer than 20% of people at risk who seek testing end up ultimately choosing to have testing for Huntington's disease. It's a small percentage. Less than 20% choose to have the testing. It's just very different from what you see in almost every other condition where testing rates are really high. I think it speaks a lot to what people, the impact potentially of this, of knowing this information and the fact there's just nothing that can be done. So there's lots of studies now that say people who have testing have relatively good outcomes, but you have to remember it's a very select group of people. So they're self-selecting.
We definitely have people who know they're at risk, who choose to have a test for it when they create embryos, but not disclose who the parent is, but and in a way that you would never know if it was there or not transfer an embryo, that would be a, does that make sense?
Yeah, so it's non-disclosing testing that,
I've seen that in practice questions before, and I find that question so odd, but then it's actually very common. It's actually real.
Well, I mean, common is not the word I would use, but it happens.
Sorry.
Yeah, totally.
So Carter is right.
Go through it. They go through IVF. Well, usually they're coming to IVF for other reasons, but it's still, but every step along the way it has to be non-disclosing, because if you said, like,
oh, you don't need to worry about this, then.
Yeah. So there's a lot of, like, safety things.
Yeah. So, Carter's right. This is the one that you would say was the least appropriate. All right, so sample question 2. You've got a woman in her mid-20s with a 12-year-old brother with Down syndrome seen in a prenatal clinic. She states that she's very concerned about undergoing prenatal screening diagnosis. All of the following may be helpful topics discussed in this context, except. So reading through these and thinking about which one would be the least appropriate.
I'm probably going to get.
Yeah, why do you say decent?
Well, it's not really relevant for, you're right. It's not relevant.
Yeah.
Bring that up and.
Yeah, it's not part of her context, right? She's got a 12-year-old brother, so she's probably not experienced that piece, and it's not something she's asking about. It's likely not the thing that's highest on her concern level. So, yeah, that's how you think about that. Again, it's not that that's a completely irrelevant topic, but it's not as relevant in the context of what they're describing. All right, third question. 16-year-old boy with NF1, moderate intellectual impairment, accompanied with annual genetics visits by his mother. He asks you, the 16-year-old boy asks you if his children will have the same bumps and freckles that he has. And his mother quickly changes the subject, asks you a different question. So what's the best way to respond to that scenario? Why? Yeah, it's assessed, right? That's the opportunity to get to understand what's behind the question before you start to answer the question. So a lot of these questions do get at sort of the basic communication that some of this is not specific to genetics or genetic counseling. It's just basic good communication skills that are important to know in the context of genetics as well. Okay, sample question 4. 40-year-old Peruvian woman with a recent diagnosis of breast cancer referred to the Hereditary Cancer Clinic, accompanied by her 8-year-old twin daughters, who explained that their father wanted them to serve as interpreters for their mother at the visit. So what's the best course of action given that they've shown up like this? None of these feel like great options, right? But, so why do you say that?
We want like a real or someone, what are real, I mean, what's the college? Of course, it's the clinic secretary though. It's not like a medical translator. Actually, the E would be your better bet for the colleague.
Yeah.
That's a long time to wait, but now.
It's a long time to wait. And those are the two I'd be weighing as well. So I would have off the top gotten rid of A, B, and D because of what your principles around the medical interpretation and wanting to support communication as best as possible. But between C and E, my thinking, even though neither of them are presented as a medical interpreter that's trained, E has a better chance of being somebody who's likely to be, who knows the medical language in Spanish. So that person is going to be the better translator if the patient can wait. So E isn't presenting, telling her she must wait, which might make you think differently about this. It's asking. So again, you're sort of reading every word and trying to decide what, is this an appropriate action? And all this is asking is to say, let's ask if she's okay, if she's got the time. This would be the best circumstance if she does. So that would be also true, right? All right, another one. So a woman has recently been found to have a pathogenic variant in BRCA2, comes to you to test her 12-year-old daughter. She says that all the women in her family have had cancer and their 12-year-old is extremely anxious about her own risks. What's the best course of action? Everybody agree? Yes. Yeah. Yeah. Some of these other ones aren't wrong. So certainly at some point if you get in over your head calling for an ethics consult may not be a bad idea. But the first thing you're going to want to do is to better understand. Because it may be that you can eliminate the entire problem if you can get to a point where you have a better understanding in the family of what's going on and what she really wants and what's really driving the mom's anxiety and the child's anxiety. So that's where you start. Okay, family of 3 adult siblings, one 25-year-old man and 27-year-old fraternal twin sisters, each of them 50% risk for inheriting a familial pathogenic variant in BRCA1, choose to undergo testing simultaneously, and they've all agreed sort of in the family counseling session they are going to share their results with each other. One of the twins is positive for the pathogenic variant, the other 2 are negative. What's the most likely psychological concern that you could anticipate given that scenario? Yeah, so survivor guilt is, and so again, all of these are possible, but you're sort of getting at, reading the scenario and thinking, what is this scenario set up to help? What was this scenario trying to test? And it is this concept that survivor guilt is very common in this kind of scenario. It's been very well studied, and we know this is objectively something that happens quite frequently.
It has been studied in Huntington's too.
Yeah, and also very common there. Common in actually a lot of dominant conditions. A woman with a strong family history of colon cancer proceeds with cancer panel testing and a pathogenic variant identified in a Lynch-related gene. Her brother comes to you for counseling to consider single-site testing. He expresses a concern that genetic testing might mean that he would be labeled as having a pre-existing condition for insurance purposes. Which of the following is the most accurate response to that concern? Yeah. And I actually don't think you end up with this, I don't think this kind of a question exists on the board exam. I don't think you get to both A and C and neither A nor B, but I was struggling to find something that felt realistic in terms of response options for this one. But I think Gina is there are likely to be questions on Gina in your counseling section. So just making sure you know that law and what it does cover and what it doesn't cover. So in this case, I think that A and C both represent potential holes in that you'd want something to be aware of.
It's not life disability or long-term care, right?
So a 29-year-old woman found to have a known pathogenic variant in BRCA2. Upon discussing risks to other family members, the patient revealed that she is estranged from her mother and has no desire for anyone to communicate with her. The most appropriate next step, given that she said that, might be why do you say B? It's assessed again. Yeah. And again, it's because it's the sort of the next, if the wording says next step. This may not work. It may be that you explore, you try to get a better sense of what's going on in the family with the idea of trying to help convince her to get to a place where she can share this information, and it may fail. But it is absolutely what you'd want to try first before you did anything more, even considered anything more drastic than that.
In a scenario like this, will they probably ask us a more stringent type of answer in terms of legal implications and what you should really do by law?
They may. The tricky part is, so I can speak again with my ABGC hat on and not for how our item writers are instructed to write questions where there's at least a clear answer, even if it's subjective, but the principle they're trying to test, at least there's a clear answer. And so I think it would be fair to say you should know what the legal, enough about the legal cases to be able to say what previous legal statutes have said, and we can talk for a few minutes about that. But it's actually not clear. It's not settled case law. So, which is why I didn't ask that question, because I think it would be
like one that's specific for genetics, right?
There's been a couple, and one came down on the fact, it said that the provider wasn't under any obligation to do more than inform the patient, and the follow-up case, that was a completely separate case, the court ruled that it might have been a responsibility of the provider to go forward and try to take further steps besides. So it hasn't come up again. Family disclosure. And so in circumstances, it's a duty to warn case. If your patient, what is your duty to warn other at-risk family members? And this only really comes up when you're talking about conditions that are severe and medically actionable. So the case law doesn't say that there's a duty to warn outside of that. But if there's something that was severe, medically actionable, and as a provider you could reasonably have identified who the person was, then there is a question that you may have the duty to warn if it's clear the patient is not going to. Exactly.
It will be fair to say that you have a duty to warn if you have one of the 56 genes from HNG?
Yeah, I mean, I think nobody has tested that exact question, but I think it would follow the previous statutes that if that based on how those rulings have gone, that those are 59 genes where there's action of that a group that's very well accepted has said they're medically actionable, that it would make sense. Now, it probably also depends in the case whether you're talking about somebody for whom there might be imminent risk versus long. So if we're talking about a child for an adult onset condition, the case might go differently than if it was an adult. But all of this is relatively untested and is still a very active area of writing. So I would be a bit surprised if they ask you to make a determination in that case. But they may ask you a question that gets at the fact that we don't know, or that there have been differing opinions in the courts, and that there may be a duty to warn. So you're seeing a 65-year-old woman whose maternal grandmother had a diagnosis of Alzheimer's disease, and this is a woman you're seeing for an initial consult. Her family history does not appear indicative of autosomal dominant inheritance, so it's just the grandmother when you take the family history. But the patient expresses a strong interest in ApoE testing. Which of the following would be the least appropriate next step given that? I heard least appropriate. Least appropriate, not most appropriate. Yes, you have to make sure you read the questions carefully too.
And read out the options. I noticed that.
Yeah. D by D. Right. So for similar rationale to the Huntington's case, and this one's even more murky in some ways because it's not clear that the ApoE testing is going to give her anything. So you really want to understand what she's really seeking and help her to get to a place where she understands whether this is really going to help her. So yeah, this is a case where testing is. So again, I know I said at the very beginning that often you want to go toward questions that promote patient autonomy, but there are obvious exceptions to that. And so in scenarios like this where respecting patient autonomy means ignoring an opportunity to get to help the client or the patient be more clear on their own values and attitudes and beliefs, and you're just going straight toward, I want to protect autonomy, so it doesn't matter, then that's usually the wrong answer.
I guess maybe except if it's a prenatal situation, right? Because if it's a prenatal test, I mean, the mother's distress is supposed to be a sufficient reason to proceed with testing, right?
Well, so would you say in this case, if the mother was saying, I want ApoE testing on a fetus, would that be?
No.
No.
ApoE, but like something related with prenatal type of disease that may be affecting the baby.
Yes. So you're saying if this was a person coming in and saying, I want testing for X, Y, and Z in my, that's relevant to to a child, to a fetus. Mm-hmm. And so your question is, would you?
Well, from a prenatal sense, they're able to request. I mean, they could walk in and say they want an embryo, and the answer is yes, it can happen.
Yeah. But that's because we have guidelines that say they can have.
Yeah. But this one's different. It's the murky test.
Yeah. So if you're asked a question that seems to be about an ethics question, but you recognize in the STEM that there's actually something where there's a practice guideline, the practice guideline trumps any other discussion that you might have with yourself internally. So you have to think first about what is the practice guideline telling me. So those are things that you should definitely be familiar with in terms of, I would look at, and I've got a resource list at the end of my presentation, but things looking at NSGC and ACMG's practice guidelines to make sure you know those really well. So you're consenting a trio, mother, father, child with autism, spectrum disorder for exome sequencing. Given just that very basic scenario, which of the following is the least appropriate for inclusion as a part of the informed consent process? Why do you pick C?
Secondary finding is very fast, with the same normal assignment finding.
Yeah, so you're thinking the secondary finding is secondary, and so it's not as important. It's actually, this one is worded in a tricky way because as of right now, the general recommendation would usually be that you can and should talk about the option of whether you want to receive secondary findings or not. And but the way this is worded, it's not a discussion about whether to receive secondary findings, it's a discussion about which to receive, and that's not sort of standard of care at this point. If you're either opting to receive secondary findings or not.
Right. Okay.
So I'm reading very carefully. And I would say, as a general rule, if you read through and you're like, all of these seem okay, then go back and read them each really carefully and say, what might be tricking me up in some of these? There's probably. So that's just the one. So C is, yes.
So you're saying that it is okay for a patient to opt out from receiving secondary effect, or you're saying that it is not clear if a patient?
No, it is okay. Actually, so the original ACMG paper said no. Absolutely not. People should receive secondary findings. They have to know that in consenting to exome sequencing that they're consenting to receive secondary findings. But the follow-up paper actually, after lots of discussion, backed down from that a little bit and said it is appropriate, although I think members of that group, many of them still felt strongly. The consensus was backed off a little bit and said it's okay to offer an opt-out, but it still is a bucket. It's either all you get the secondary findings or you don't. And if you look at what most of the labs are doing now, they mostly have that opt-out. And so I checked today to be sure that Invitae, GeneDx, and Baylor all have the opt-out for secondary findings on their consent forms.
Oh yeah, they don't. It seems they don't look at it. It says no, and like the search doesn't come up.
Yeah, that was a very contentious point in the original ACMG paper because the labs got very upset and said, we don't feel it's appropriate to be giving people information they don't want, and we also don't want this to be a deterrent to people getting exome sequencing for their primary indication. 35-year-old woman comes for genetic counseling because of a family history of polycystic kidney disease, consistent with autosomal dominant inheritance and confirmed by review of medical records in her family. Genetic testing has not been performed on anyone, and her own renal ultrasound showed a single unilateral kidney cyst. But the patient, based on that, says, well, now that I have PKD, my children are at 50% risk to have it too. They need to have DNA testing. Which of the following is the best response to her statement? And again, so I've got down here, there are a few in here that I actually stole from ABGC as sort of their public ones, but I thought they were good questions. So. Why? Right, so that just makes good clinical sense to test, to at least explain that first. Yeah. Okay. 27-year-old, 9 weeks pregnant, who has a nephew with Down syndrome. The woman expresses to you that she's concerned about the risk to her current fetus, which is the following is the best first step in counseling this woman about her risk. So the best, not a least. What do you think? Okay, so we got a C and a D. Oh.
I want D because, I mean, that's, if you can get it, I'm sure it's the best, but I know you almost know. She's 9 weeks pregnant, you don't want to miss the boat. So, probably, more likely is because but
Right, but again, it's sort of thinking about the best first step, and you're right that it's the answer that ABGC gives to this is D, but the rationale is that you can ask, you should also keep your 9 weeks window in mind. If it turns out that the patient says, oh yeah, they live next door to me and I'm sure I can get that to you tomorrow, then great, then you're in much better shape. If not, then you're probably going to go to C.
But you're right, because it's about counseling her about the risk, right? And specifically, she wants to know in light of her nephew. Out of curious, you don't know how to counsel her, but I'm 27.
Right, but her primary risk being about this is, yeah, and that will vastly change what her actual risk is as a 27-year-old.
Sure.
Okay. 35-year-old woman, recently diagnosed with invasive ductal carcinoma of the breast, comes for genetic counseling with her 30-year-old sister. Their mother died of breast cancer at age 52 and was the only other affected relative. To determine the risk to the 35-year-old woman's daughter, the woman has comprehensive BRCA1 and 2 genetic testing with negative results. Which of the following statements by this patient should make the counselor most concerned that she does not fully understand the results? Yes, see why? You're right. Right. So that one is, I mean, they're all slightly wrong, right? But that one is the most objectively wrong of those. If she says that, you can sort of see how a person might have hold the other opinion. Certainly B, her daughter, BRCA testing isn't going to be useful for her daughter, unless her daughter's father has a family history. But that's, so that one is probably, it's fine. A, certainly they've ruled out the 2 genes that have the highest risk for ovarian cancer, so it's a reasonable thing for her to be thinking about. And she could still be considering a bilateral mastectomy because she still has an increased risk, and she's got cancer. So C is the one that if you were trying to look through each of them. Yeah.
Like the never always.
Exactly. Right. There's not any way that that is a correct understanding of what's happened in C. That's the best answer. Okay. A genetic counselor meets with the parents of a 15-year-old girl who was recently diagnosed with Turner syndrome. The parents do not want their daughter to be informed about her diagnosis because they feel it will upset her, and they prefer to wait and tell her themselves when they think that she is ready. Which of the following is the best approach by the counselor? A. Why A?
Communication, empowering the patient, smart, fathers.
Yeah, B is a good answer too, but B is sort of like, you're like shipping off the discussion to the worker.
Yeah, you're not actually helping actively facilitate what's happening. A is the one that most engages the patient and respects where they're coming from and allows them to potentially get to a place that works for them. So when I said at the beginning, you're trying to enhance patient choice, enhance their options, but while also sort of moving toward a place that's best for everyone, that's the one that optimizes all of those. Okay. 22-year-old woman, 20 weeks pregnant with a fetal ultrasound which showed spina bifida and slightly enlarged cerebral ventricles. After the genetic counselor discusses the possible diagnosis and the unpredictability of the outcome, the woman expresses her reluctance to terminate the pregnancy. Her husband remains very quiet, says that he will go along with his wife's decision. Which is the best approach for the genetic counselor to take? Why? SS. Yeah, so this allows him, you don't have any idea what's going on for him based on this scenario, and it allows you to then get a better sense of how the couple is doing. So that's the right answer. Doesn't mean that you wouldn't ultimately get to a point where family therapy might help them, but you have no idea yet whether they actually have a disagreement. So we're not there. Suggesting that the couple continue the discussion at home abandons them, and supporting the woman's decision likewise sort of just focuses on what she's told, the overt things that she's told you, and not better understanding the entire context. So always try to understand. You have a follow-up meeting scheduled with a 62-year-old patient and his wife to disclose the results of recent genetic testing that has confirmed a diagnosis of ALS based on the characteristic expansion of C9orf72. Which is the most appropriate description of the setting that you want to have this conversation? You said which one? A? Which why? You're unsure.
I'm thinking.
Okay. What? Or so why don't we try, which one would you eliminate? What would you eliminate first? Okay. Why eliminate B? Yeah, so A, this formal conference room, and you're maintaining a neutral, there's no compassion there. So you get rid of A.
And I really don't know if telling the results right away is a good thing or a bad thing.
Right.
Like, I don't know.
Right, so the actual answer here is C, but this is tricky because, right, so the issue with B is that you're starting from a place of uncertainty. When and it's fine if there is uncertainty and you're going to get there, but if you start there, it's really much, it doesn't give anybody anything concrete to hang on to. So that one I would eliminate just because starting from a place of uncertainty or from a place of controversy, so likewise if you've got two people on your team and you have differing opinions, you don't want to start with the differing opinions or the controversy. You want to start with, especially when you're delivering bad news, start with something that's understandable and clear. And D, D actually I could argue with C as well. So depending on how much background.
What do you mean about how long are you going to go on and on? You're wondering, what if B?
Right. So and this may be, I mean, this is one that I made up, so it may be that I should reword this in the future, but what you want is to avoid one that's going to mean that you need to cut to the chase pretty quickly when you're giving results. And so looking for something that allows you to get cut to the chase pretty quickly.
Well, the other thing that in the question is we call it a follow-up meeting. So it's not, presumably when you ordered the test.
You had some conversation.
About the test. So they're here to get the results.
Yeah. Yeah.
Timing though. I was just reviewing a case of my student, my supervision today, like it was about axon disclosure, and it was like months later she felt the couple didn't remember anything about the three counselors.
Yeah. So I think this is it's worth talking through. The principle this one was trying to get you to is sort of thinking about what are the contexts of giving bad news. And there are lots of publications on what are the things you want to highlight when you're giving somebody bad news. And the general things are you want to be compassionate, you want to establish a relationship. So anything that's saying I'm in a formal conference room, I'm sitting far away from somebody, you want to be clear with your messaging. So while a lot of this may have uncertainty and it's appropriate to bring that in later, the messaging should be pretty clear up front when you're giving bad news, and you should get to it pretty quickly. So those are the general principles that you're looking for there. Probably a poorly worded question on my part, but
I believe you can say like the principle here, is there like a really like clear set of principles we could get somewhere just go through and
I wish it was that, but so they typically write these questions based on publications in genetic counseling. So one of the things I'm going to recommend, and it's on my resource list, is there are a couple of sort of common textbooks in genetic counseling that go through the psychological approaches to genetic counseling. Those are probably worth a quick skim because they'll hit the highlights in terms of here are some general things that, but mostly the principles are patient-centeredness. So that one I've been hammering home. So the right answer to the question is generally going to be get to know your client, get to know them well, help facilitate as opposed to tell. And then, so the bad news discussion, there isn't like a guidelines, best practices on giving bad news, but there have been lots of people who've written about giving bad news, and it's included in the genetic counseling text as well. What are the things you want to think about when delivering hard news?
I remember on the in-service that one thing that's a little bit concrete to review are the 4 ethical principles. Like I remember questions that actually said, this is an example
of autonomy, beneficence, justice, non-maleficence.
What the definitions are, and maybe have some examples in mind. I think that'd be like easy.
Yeah, and the guide to genetic counseling, which is the top book that I recommend, has their chapters based on a lot of the. So you can look and go to the chapter on ethical and legal issues, and that one's probably worth a read. And it will go through autonomy, beneficence, justice, non-maleficence, and talk about them each in a genetic context. So those would be good and not really, they're not long, cumbersome things to read. And
there's always a question about child, like a minor.
A minor, Yeah, and it's important to note that the thinking on minors has changed. I think I may have a minor question coming up, but.
Revise the statement?
Yeah, so the statement used to be very clear you'd never ever test a minor for anything except a diagnostic testing, and now,
we do it all the time.
Yeah, there's more wiggle room. It still says, for pre-symptomatic, non-actionable in childhood conditions, you would rarely test a child, and the only times you would consider it might be if there was a really strong family reason for the good of sort of keeping the family unit together. Maybe there's extreme parent distress, and the team decides, based on extensive conversation with that family, that this is the best action, but it's in the rare circumstance. So they've opened up this very rare circumstance window now that means
every single day with excellent sequencing. It's just always, I have to look at the new guidelines. I was just going to say that everybody keeps saying that these questions are like old, so the answer is right.
Yeah, so that's a good point to keep in mind. So as you're studying, recognizing these questions were written at least from the ABGC standpoint, our questions all have to go through like a year of pre-testing and reviews. So by the time they're actually on an exam, they're at least 2 years old. So if there's a guideline that comes out tomorrow, it's not going to be in your exam. So which describes a research scenario in which you would likely not need to obtain informed consent for the participation of a participant's family members? So this is, we can talk about what it's getting at, but so which one would you likely not need their informed consent, extended family? Yeah, C is normal history taking. Yeah, why were you, so C, we were thinking of C also because that one, it doesn't involve the primary participants themselves, but it gets at, so that the right answer is B. And this was something that was actually quite contentious 15 years. There was a period of time about 10 or 15 years ago where there was a whole question of can we even take family histories as part of a research project without getting consent from all the people, because you're actually making, these people are identifiable human subjects. If you know the identity of the participant who's the proband, and they tell you their mother or their first cousin, and they only have one female first cousin, that person is identifiable and they haven't consented to have their information. And there was a whole period of questioning whether this was going to throw everything. And it sort of, after much discussion, there have been sort of additional guidelines and research to help people understand what is appropriate and what is not appropriate. And the consensus is this is considered okay, largely because this is self-reported data on the behalf of the proband, so these are not confirmed medical, right, exactly. So if you were doing this, though, you are actually, with C, you are actually asking for identifiable information from a person and their health status. Potentially that's a little bit more identifiable, and you'd at least need some level of consent. So what you'd have to do if that's what you wanted would be to send home a consent form with your proband and say, get this from your...
I'm confused, but it's just in my head.
Yeah.
I remember reading somewhere, somehow, that there's something about, like, if you get family history from your patient, the patient's information is protected by the consent, but the family information is not, or something like that.
Well, that was the worry. That was absolutely the worry. So as I said, 10 years ago, people were quite worried that we weren't going to be able to take family histories without getting consent. In a research setting. In a clinical setting, it's different, but in a research setting, there was a case, I forget what university, I think University of Virginia maybe, where they shut down all of their research for a little while because there was a concern that there had been a family member who'd been identified as part of a family study through a pedigree and who said, I never consented to have my information in that study. But what people are saying, the general consensus now is that you can do this because it's not, the health information you get on these people is from the perspective of the proband. And so it may or may not be correct. It's not the same as the proband saying, here are the medical charts of all of my family members. It's saying, this person has diabetes, this person was born prematurely. It may or may not be correct information, and it has been considered okay. So it is appropriate on the exam to select that one you wouldn't need consent for. But pretty much anything else, any further level of information on patients' family members, you would need potentially consent. And it will vary a bit from IRB to IRB exactly how strict they're going to be on this. But generally speaking, if you're getting names and contact information from a person, that person is now an identifiable person for sure. And the information you're getting on them is considered PHI, and you need consent to get it. Okay. I think this is my last one. 2 years ago, you saw a 22-year-old woman whose cardiogenetics panel test showed only a variant of uncertain significance in a gene that had some phenotypic overlap with characteristics in her family history. She has not returned to clinic for follow-up, but does have another visit scheduled in 9 months that we think she might come to. And the lab just sent a revised report that reclassifies the variant as likely pathogenic, which describes the best next course of action. So what should you do when this happens? What'd you say? A. Why A? Yeah.
Then now they have the kind of form, so I think the patient needs to know.
Right. Right, and this is potentially actionable, right? And you.
This cardiogenetics, you start to.
Yeah, right, exactly.
Yeah, exactly.
Right, so it may be with a different context, it might not be as clear cut, but when it's an actionable result, for sure, recontacting immediately is almost certainly going to be the answer.
Following like it's a pathogenic variant, maybe.
But you haven't seen her. This says she hasn't returned to clinic for follow-up. You haven't seen her in 2 years. You may not know. Yeah, you saw her 2 years ago.
As a laboratory or as a clinical practitioner, are you required to do that? Like, are you required to actively look for which variants may have changed, and if they are now pathogenic, and if they weren't? Are you actually legally obligated to call the patient?
It is a bit unclear at the moment. The labs are all, I think, feeling a lot of pressure to to notify the ordering physician. So I think many, Jen, you can speak to this, I think many have now databases where they're keeping track of who's got what variants, and when things get reclassified, it sort of is as a batch, it goes back out to anybody who, the ordering.
know about, like,
From a panel test or from a,
so many changes, like,
it's so much.
I know that you have like different designs over the years, you know, the colors may change.
yeah.
Regional may
Don't
see
you
the
guys
same.
say, or, I feel like I learned with the GDX, that there's like a thing where you tell the patient, you know, feel free to contact us in a year.
Yeah, they can reanalyze, for
Or
sure, like an Excel, they can
Right.
reanalyze.
We do that all the time, if they call
Yeah,
us,
for free.
we read that.
Yeah.
We change that for you.
Yeah, well, and routinely we would say in clinic, you know, I haven't been in a non-NIH clinic in a few years, but when I was in clinic before coming here, we routinely told people on any test that they had a VOS on, it could change, and you need to keep in touch with us. So we didn't put the onus, we always had the conversation, but we put the onus on the patient to come.
No way.
Yeah. So the key here was that if you're a provider who's gotten a revised lab report, this is why the onus is down on you, because you perceived this, you now know something that is actionable for a patient. So it doesn't say, I wouldn't read this question the same if it said, should you be contacting the lab to get these things revised on a routine basis. There's not a clear duty at this point if that's the case. But if you've got information that says it's been revised, it is your duty to reach back out. Okay, so that's my spiel. Other topics not covered, but certainly of potential relevance to genetic counseling, but that I think fall under other aspects, other parts of the outline, pedigree analysis, Bayes, anything that's, any risk assessment related question is fair game. And then as I promised, useful references. You guys got my slides, right? You've got this. So the Guide to Genetic Counseling is it's a big book, but it's an easy read, and I would skim the contents and focus on the things related to ethics and legal issues. The rest, I think, the general psychological questions, most of the time you're going to be okay with just trying to really focus on what's in the best interest of this patient and how do I give them choice most of the time. So I don't think you need to read up on all therapeutic genetic counseling. That I think just generally thinking what's good patient care, what's patient-centered care is probably reasonable. And then looking at the practice guidelines, there are, if you're really interested in more ethics work, there are a couple of other ethics case books in genetics which could be interesting, but if you're looking for just a quick read, probably the ethics chapter in the guide is reasonable enough. Read up on your genetic discrimination GINA resource. There's very brief readings on that. That's probably sufficient. Some of the other ones toward the bottom of the genetic counseling books are, if you're just really interested, feel free, they're great books, but the Guide to Genetic Counseling is going to be your quickest, easiest, and likely to have the lowest hanging fruit in terms of studying for your exam. And if you have questions, you're always welcome to reach out. I'm happy to create more questions to go through. Thanks. Thank you guys for, I was really worried when there were only a couple of you that my interactive session was going to be over in 15 minutes. You guys played along, so thanks. And Carter, I'm sorry I'm not staying, but I've got to
That's all right.
get the kids.
No problem. Some interesting questions like, your patient was drunk, what do you do? And then the other one, I don't remember the different scenarios, but I could always narrow it down to two, and like, how do you decide between those two? And then there was one, the lady looked like she had a cluster, but you asked her directly, like, what is that scar? So
Right,
hard.
here's the thank you.
Yeah, these are much better than
That's hard in real life.
They're really hard questions to write. They are very hard to write.
Y'all want a bio break? No? Okay. Trying to see if I can load my computer real quick.
Yeah,
If y'all think, I really tried hard to look through what we had on the share drive to see if I could find like some example questions that cover these topics. I couldn't find anything, which is super annoying. But if y'all think of a question that was on the like the in-service, because I didn't take it most recently, because I based this on what I remember and sort of polling the audience, people who've taken the test, say like, what do you think is most high yield? And obviously I'm not a male infertility expert, so I'll do my best. But yeah, stop me if y'all think of a question and we can talk through it. This is going to be like a study group,
So I'm a student and a teacher, apparently. Okay, let's see.
Thank you for giving this lecture. Somebody, I can't remember ever having this.
Yeah, she mentioned someone named Susan Black. I don't remember ever having that lecture. I don't know.
She's an OB, but
Yeah, I'm not sure. All right, so we're going to talk about male infertility. So first thing, this is sort of set the stage. When we get, like all this is going to be based on an abnormal semen analysis, typically. So I started the things that really matter when you're looking at a semen analysis. So volume, concentration, motility, morphology, and for the purposes of genetics, it's usually going to be your sperm concentration. So just a quick point about semen analyses. They took a bunch of guys who had all had children, they had them give a sample, and they plotted them on a bell curve. And then they took the lower fifth percentile and they said, okay, we're going to call this abnormal. But what I just told you, that all the guys on the curve had a baby, right? So the only way, like when I'm counseling patients, the only way to like say there is no chance that you're going to get pregnant on your own is if the guy has azospermia. But by convention, WHO and the most recent guidelines are from 2010 say that the concentration should be greater than or equal to 15 million. Okay? But obviously, like, I mean, I saw a semen analysis today that I was reviewing. The guy had like 182 million. There's a very wide range. Yeah. Okay.
Less than 15 is oligospermia.
Right. Yeah, and we're going to go through that.
and is there a lot of variability?
From sample to sample and individual to individual.
Okay.
Yeah. And we tell guys 2 to 5 days of abstinence before they do the test. But, I mean, sometimes they don't follow that guideline, so, you know, kind of all over the place. All right. So genetics is going to account for about 15% of male infertility, and it contributes to all the major etiologies of male infertility, including having too few sperm, having some sort of obstruction or dysfunction of the like the VAS or other structural components of the system, having central issues, hypothalamic pituitary issues, and then something like the sperm is like morphologically abnormal. And then, like I was saying, men with azospermia, so no sperm, are at the highest risk of being carriers for a genetic anomaly, up to 25%, and that risk is going to decrease with increasing sperm output. And this is one of like the main principles of this whole thing, is there's an inverse relationship between how many sperm and the risk of there being a genetic anomaly, with highest being 0 sperm. So when the test varies from practice to practice, publication to publication. Some people say any guy with azospermia should have a genetic evaluation. Some people say if you have less than 5 million. Some people say if you have less than 15 million. Some people say if you have less than 10 million. You know, here I say that these people have been quoted to say that 14% of men with severe oligospermia, defined as less than 10 million per ml, have chromosomal abnormalities. So that would be your cutoff. And then some people say you should screen all infertile patients. So it sort of varies, and there's no right answer. In general, when you're doing a quote-unquote genetic workup for male infertility, you're going to be doing a karyotype, you're going to be looking at the AZF microdeletion testing, and then there may be certain candidate genes you may be screening for, and about 20 to 30% are going to have a cause of infertility identified with this testing. Why would you be doing the testing? You could be looking for diagnosis, prognosis before a sperm extraction, which is the TESI, personalizing their therapy, you know, depending on what they need, like what I do in clinic, and then obviously genetic counseling. In terms of prognosis before a TESI, you have to do this AZF testing because there are the different subtypes, and then I've given you the mnemonic that I always remember, which is AZF-A is always azospermia, AZF-B is bad, okay, and then AZF-C can try, which means that they should have some sperm usually. And so if they had A or B, there's virtually 0 chance you're going to get sperm recovery, so you shouldn't put them through the procedure.
That's a dumb question. Who does the urology?
Urology, yeah.
Particular, what does it stand for? Different.
Well, there's this is testicular sperm extraction, but then there's like microscopic, so MESA, there's TESA, PESA, percutaneous. There's all these different versions, yeah. Sometimes you're like incising the testicle and actually exposing the tubules, incising the tubule, and then like trying to get the fluid, and then sometimes you're just sort of blindly sticking a needle through. Yeah. It varies. So this is just a really helpful sort of algorithm to how to think about it, and I would say this would be like the slide that I would go back to and look at before the test, as sort of like how to put things into buckets. When someone has azoospermia or severe oligospermia, you need to think about obstructive versus non-obstructive. That's your first sort of decision point. In this algorithm, they're saying that if they have greater than 5 million sperm per ml, then you would not do a genetic workup. But like I just told you, some people would disagree with that. If they have evidence of obstruction with a normal testis volume and a normal follicle stimulating hormone level, then you'd be thinking about the congenital bilateral absence or congenital unilateral absence of vas deferens, and then consider the CFTR testing. Write this down here. Okay. Or if you think the vas is present, but they have low semen volume, and you think there might be just some sort of dysfunction, again, you're looking at CFTR testing. When I think about the CFTR testing and cystic fibrosis in general, I kind of think about it like the ducts leading from the testes out are sort of mucked up in the same way that the lungs are, and so you could end up sort of not having enough volume, I guess is the way I think about it. Non-obstructive, so I said you're going to divide into two buckets, obstructive and non-obstructive. For non-obstructive, you're thinking about primary testicular failure, like, Klinefelter. Those patients would have a low testis volume, high FSH. You could have some sort of mosaic and an incomplete testicular failure, and then you could have central issues where you would have low testis volume, but you're having a low luteinizing hormone, low FSH. And I'll go through kind of how you think about the hormone levels here in a second. And then again, down here, it's telling you sort of where these, through the algorithm, where you would go. And again, with central, the best example is like Kallman. These are like the Kallman syndrome, candida genes. Anything else? Okay. In terms of thinking about the whole hypothalamic pituitary axis, which I know for like non-endocrine people can be intimidating. So when you think about this, you just want to like, this is as bare bones as I think that you need to understand, okay? So hypothalamus is going to send down GnRH, which is the gonadotropin releasing hormone, okay? So gonadotropin releasing hormone. So gonadotropins are FSH and LH, follicle stimulating hormone, luteinizing hormone, and then that is how the brain communicates with your ovary or with your testis. So if you have a normal FSH, so you have normal communication between the brain and the testis, you're going to have normal testicular volume, and you're going to have testosterone providing feedback to the brain to say, I hear you, and we're good, right? If you have some interruption in the system, like Kallman syndrome, where you had like improper migration of those GnRH neurons, and so they don't have proper GnRH, then the brain is trying to talk to the testis, but it can't. And then you're going to have a small testes, and you're going to have high FSH and low testosterone, because it's like the brain is screaming, but can't talk. If that makes sense. I guess the other thing this is showing is if you had like so if you have Klinefelter, let me back up. If you have Klinefelter, you're going to have high FSH, small testes, and the low testosterone. That would be like a primary testicular failure. in common, you're actually going to have hypogonadotropic hypogonadism, so you're going to have low FSH and low testosterone. Sorry, that was confusing. Does that make sense? Yeah. Yeah. So, depending on where your defect is. So if your defect is the brain, and you have low gonadotropin releasing hormone, low GnRH, then you're going to have low FSH.
So that's the common.
That's going to be like common. And so if you have low FSH, then you're going to have small testes because they're not receiving the gonadotropin stimulation, and then as a consequence, you're going to have low testosterone. If you have primary testicular failure, like Klinefelter, okay, where you have a chromosomal abnormality like in the testes that is causing the failure, the brain will scream at the testis, which is the high FSH, but you will still have low testosterone because the testis is like a dud, right? It's not responding.
So in Klinefelter, it's more of a testicular problem and in common it's from the brain.
It's a central problem, exactly. So these are the different like ways to think about it. The other thing this is telling you, it's hard because where it's saying you're sharing your screen is saying OA for obstructive azospermia and non-obstructive azospermia, okay? Because again, we were dividing this into the buckets obstructive and non-obstructive, okay? This is also telling you that in a patient with, say, CF, this system is intact. There's just an outlet problem, and if you did a testicular biopsy, it's a normal testis, and they're going to have sperm. Does that make sense?
The FSH will be normal.
It'll be normal, right? Okay. And we can go through that again. I think I have a slide at the end. I know that for non-endocrine people, it's very intimidating. Okay. This is also just a really high yield slide that I would spend some time looking at. I'm not going to go through like everything on here, but this goes from most common, which are your quantitative defects, to your least common, which are the qualitative defects. And here they have some candidate genes listed and some things that are super rare that we don't ever test for, but from an academic standpoint, they exist. In terms of what we're going to talk about, I'm kind of going to stop right here where the hypothalamic pituitary genetic causes are. And then just looking at these a little bit, we talked about azospermia less than 5 or less than 10. You would you'd be looking for numerical or structural chromosomal anomalies. So you'd be doing a karyotype with azospermia or semen analysis with less than 5 million. You're also thinking about your Y chromosome deletions, like we said. This is never done. This is academic also. This text 11. I mean, I shouldn't say never, but this is not like, oh, let me order text 11. Yeah, no. And then this GR is part of the AZFC region, so I think it's just part of that testing. And then here, this is talking about an androgen receptor defect, which is sometimes tested for clinically, and would lead to, potentially having a disrupted androgen receptor, which is a DSD disorder, which we'll go through a little bit. And then for ductal obstruction, again, this is super high yield for the test. They're absolutely going to ask us about CBAVD and CFTR, like 100% is going to be on the test. I think that and Klinefelter are probably the most 2 high yield. And then for hypothalamic pituitary, you got Kallman syndrome, which is part of the bucket of hypogonadotropic hypogonadism, and Kallman specifically is where you have low SMIL, and then there's also normosmic. And so that would be a candidate, like a panel of genes. And then for the isolated gonadotropin deficiency, similar central problems. So you're targeting, it would be a target panel looking at FSH and LH issues. Okay. All right. So this is that general principle I was talking about again. Frequency of genetic anomalies, big wedge here where azospermia is, and then inversely related to how many you have. So the more sperm you have, the less likely you're going to find a genetic anomaly. And then some definitions. I think on the test they could say azospermia. I think they could say oligospermia. I don't think they would say the cryptospermia. So in this one,
sort of by definition, it would be you like centrifuge down a pellet and then find some sperm in that pellet. So it's like you're looking at like a high-powered field and, oh, I found one. That would be cryptospermia, so they're hiding. Oligo, like I said, they're there, you see them, but there's less than 15 million, and then normal is going to be the greater than or equal to 15 million. If you have a quantitative defect, the general principle is we need to look for structural or numerical abnormalities, so get a karyotype. So 15% of men with the non-obstructive azoospermia and 4 to 14% of men with a little bit of a range with a moderate oligospermia, less than 10 million per ml, are going to have a chromosomal abnormality. It could be sex chromosome, it could be an autosome, but that is like the answer is get a karyotype. The most common anomaly with non-obstructive azoospermia is going to be Klinefelter or Klinefelter mosaic. In general, it's thought that most Klinefelter patients who have sperm present probably are mosaic. You've also got the another DSD where you've got a 46XX with a SRY translocation. We'll talk about that in more detail in a minute. And then if they have oligospermia, it's more frequently going to be some sort of structural anomaly. And it might be that they have some sort of structural anomaly involving the Y chromosome, which could have issues with SRY being present or absent, could have issues with the AVF regions. And that's kind of what you have to keep in mind. So more specifically about Klinefelter syndrome, we all know it's 47XXY. It's about 1 in 600 live births. Most common defect, again, in non-obstructive azoospermia, about 10%. The clinical spectrum, like what the patient actually presents as, is going to be determined by how much androgen they have, how virilized they are, which is going to be determined by how well their testes are working, which is going to be determined by what is their chromosome complement, are they mosaic or not, that sort of thing. Most of these guys are going to start puberty, but they probably aren't going to finish completely. They typically have small sperm testes. They typically have hyalinized seminiferous tubules and sort of as a consequence, spermatogenic failure. So again, it's a testicle problem. Just you can think of it as analogous to Turner's, right, where their ovaries they get POI because their ovaries basically lose all the function and they're just little rubbery tiny things. That same thing happens with the testes. Okay, and so greater than 90% are going to have either azoospermia with the remaining having usually very few or severe oligo. Okay. This is just, showing the different signs we might see that, again, are directly related to the androgenic deficiency. So having gynecomastia, having a euchenoid habitus, having this undervirilization, forebeard growth, not having your male frontal baldness. And again, when does Klinefelter present? It's usually, well, one, it could be your NIPT testing, because we do that all the time. Two, could be at puberty, because they start, but then it doesn't seem to be going right. Or a guy comes and he's infertile with his partner, and then you find out that he has Klinefelter. And then just as a side note, we're all going to need to know this syndrome as one of our big syndromes to know, but they can also have metabolic syndrome, they can also have autoimmune disease, blood clot issues, cognitive and psychological disturbances, anxiety, depression. Yeah. I think this is one of our, the big 100 syndromes we have to know, right? Okay, and then a little bit about sperm extraction. Up to 69% of men will have a successful sperm extraction, but it's pretty much directly related to the age when you do it. And there is, push to identify boys early and as soon as they go through puberty, because you don't make sperm till puberty, but once puberty starts, to try to do fertility preservation to try to save some sperm for them, because eventually their testes are probably going to become the firm, rubbery, not working ones. And then when we do sperm extraction, we're going to be doing ICSI, which is the intracytoplasmic sperm injection. That's one way to fertilize. You know what I'm talking about? Oscar, you know? So you can put the egg in the dish and let the sperm swim up to it. But you can also do ICSI where you you have a little pipette that holds the egg in place, it's got a little vacuum, and then you actually take a needle and you put it into the egg, and you actually inject a single sperm into the egg. After you use this little thing where you whip the tail to make it not work, because otherwise it'll destroy the egg. But yeah, so it's a tail not working, sperm into the egg, yeah.
How do they do that?
And it was an accident that they figured out how to do this. Anyway, but we do it all the time. Okay. And so we pick the most beautiful sperm we can find, and then we put them in. Okay. So the other point, and this is what we talked about with Dr. Mack a little bit, is that there have been many live births with normal karyotypes. And yes, theoretically, there will be an increased risk of aneuploidy, but when you get all the way to live birth, like we know, most of those are going to get sort of eliminated anyway. So if a guy came in and he's Klinefelter and they're going to undergo IVF, I would absolutely recommend that they do pre-implantation genetic testing, right? That's sort of a no-brainer, but in general, you can reassure them that they have a really good chance of having normal. And we think that if you have sperm at all, those germ cells are probably mosaic, and that's why they're producing sperm. Okay. Yeah, so factors that help predict that you're going to have a successful sperm extraction, some of them being controversial. Mosaic pattern, like I said, normal facial hair, so again, evidence of androgen exposure, so it means their testes are working. Absent gynecomastia, another evidence of androgen exposure and testicular volume thing. So then 46XX testicular DSD, so moving on to a different thing. This is also known as Diller-Chappelle syndrome, that's the eponym, and then 46XX male syndrome, and this is, you're going to do a karyotype and, it'll be a guy, but he's 46XX, and then they do a fish for SRY, and they find out he's got SRY, translocated. So then, I don't know if we get a separate lecture on DSD, and I guess in the future, if Dr. Hart has me give this lecture again, I would include DSD, because I think it's obviously, I think it would be high yield. So I'm going to go over it just briefly, but we have to remember that there's the genetic sex, there's the gonadal development, and then there's anatomic sex, and I think this is the best chart I've ever found that sort of goes through it. But if you have a Y chromosome, presumably you have an SRY, but if you're 46XX with SRY, you're going to go down this path also, and SRY is what leads to your testis, and if you don't have SRY, we call it the default, right, is that you're going to get the ovary and become female. And if you have a testis, you're presumably going to make testosterone, and testosterone is going to be what is going to give you your male external genitalia. When it gets converted to DHT, it's going to be what preserves the Wolffian ducts, and obviously male brain, but then also going to produce anti-Mullerian hormone, which is going to cause regression of the Mullerian duct, which is what leads to the female internal genitalia. And then testosterone and insulin-like peptide 3 also has a role in testicular descent, which becomes important when you talk about cryptorchidism. And then again over here, when you don't have the Y, you don't have SRY, you get an ovary, you don't have testosterone, you get regression of the Wolffian duct, you get female external genitalia, you get no anti-Mullerian hormone, so you preserve the Mullerian ducts, and you have the female internal genitalia. Okay? And again, all of that starts with SRY, and its downstream partners, and I think I talked about the downstream partners in a few slides. So for 46XX testicular DSD, where we said that Klinefelter was like 1 in 600 live births, this is 1 in 20,000, so rare. 80 to 90% are going to have translocation of SRY onto the X. And then the most important thing to remember is that the rest of the Y chromosome is typically not there, so you don't have AVF. If you don't have AVF, then you don't have spermatogenesis, and if you don't have spermatogenesis, you're not going to do a testicular extraction because there's no sperm. So knowing that this is your diagnosis is going to definitely impact your care and what you would offer that patient. This would be a patient who would need donor sperm. So 10 to 20% may be caused by activation of genes that are downstream from SRY, like I was saying.
In that test determination cascade, one example would be a SOX9 dislocation. I don't know in what detail they will ask us this, but I feel like they focus on SRY. Any thoughts? Yeah. Oh, so here's that slide.
So the thing is 91 is 20,000 million size one?
Yeah, it's a good question. 1 in 20,000 live births is what I read. Would you call it male because it's 46X? I think it must be all live births, to be honest. Okay. For the testicular determination cascade, again, we start, I didn't say this before on the other slide, but you start with a bipotential gonad, and then it's SRY that then sends you down one path or another. And there are other, like, sort of, quote-unquote, female genes that are also involved. But downstream of SRY, SOX9, like I was saying, so if you have a duplication of this, you could also interrupt. DAX1 is also one we talk about a lot, so it's SF1. Yeah. In terms of structural anomalies, like I said, they can involve the Y chromosome, they can involve an autosome, you can have isodicentric truncated ring Y chromosome like Angela had been talking about, and the main question is whether AVF is affected, like I said. And you would offer the sperm extraction dependent on whether that region was affected and how it was affected. They could also have Robertsonian translocations, inversions, reciprocal translocations. Again, karyotype is what we're ordering when they have the abnormal semen analysis. And it's tenfold more frequently found, these structural problems, if the oligospermia is present, like we said, because inverse relationship between how many sperm you're making and what your karyotype is going to be. And if they're undergoing IVF, offer gram-presentation genetic testing because of the risk of paternal transmission of your chromosomal abnormality. And I don't know if y'all know this, but the new terminology, I know before we were saying PGS and PGD, the new terminology is PGT, and then you give it like another letter. So pre-implantation genetic testing, A for aneuploidy, M for monogenic disorder, SR for structural rearrangement. Those are the main ones. So again, Y chromosome microdeletion. So now we're going to talk specifically about the AVF region. They're located at YQ. There's the three, they're called azoospermic factor regions, AVF regions, and they're all associated with spermatogenesis. I told you there's A, B, and C. And they're detected in about 5 to 10% of men with severe oligospermia, up to 10 to 20% of the non-obstructive azoospermia. So if you had a guy with severe oligo or azoospermia that was determined to not be obstructive, right, so their outlet's working, then you're definitely including Y chromosome microdeletion in your testing in addition to the karyotype. This is just the schematics, and I know Dr. Meck had also gone over this. Her slide's better than mine. Most deletions of AVF are de novo, which makes sense, right, because they shouldn't be passing it on if they aren't making sperm. But AVFC would be the exception, right, because we said that A is always azoospermia, B is bad, and C can try for that testing. Okay. And that's what this is telling us over here. Okay.
Have there been reported families where like the AVFC?
I'm sure there have been. I am not familiar with the medical literature on that. For Y chromosome microdeletion, again, we talked about how the testing has prognostic value, guides the choice of your microdissection, TESI, ICSI, versus telling them they need donor sperm and or adoption or childless living or whatever you want to say. So again, there's the mnemonic. Yes, 60% of the Y chromosome microdeletions of those patients they're not going to have retrievable sperm. And so, let's see. So for C, among infertile men, AVFC is the most frequent de novo microdeletion of the Y chromosome, about 1 in 4,000. And they present, again, with severe oligo in 2 out of 3 cases, and the remaining men usually are azoospermic. But you'll have retrievable sperm in about 70 to 80%.
and then they can do IVF-XC and have good results. Like I said, you just need one good-looking sperm to put in the egg to make fertilization happen. So as long as you have one, you just need one per egg. And like we said, you're going to transmit that from affected fathers to all sons, which could result in compromised fertility, which, you know, obviously is a little bit of an ethical dilemma, but,
In this case, with, eggs containing
say it again.
like when we know like why is already problem, so with only female cause next problem.
I mean, I think that would definitely be part of your counseling, that you would say, like, by the way, you are obligated to transmit this abnormal Y to your male embryos, and so you would, I mean, we'd probably have to have them sign a waiver to say they understand that if we're going to transfer a male, and make them understand that if we transfer a female, that, you know, this obviously would be a non-issue. But I still think you would let the patient have the autonomy to decide that, because obviously they're in your clinic with this abnormality and you're helping them have a kid. So the same thing could be true for their son. Yeah, and there are partial AZFB and AZFC deletions that may exist and be compatible with normal sperm count or reduced sperm count amenable to successful sperm extraction. So, like I said, B is bad, C is can try, and A is the one that's always bad, 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 bad. Okay. I think there have been case reports for AZFB. And we're going to see the Y microdeletion again in like 12% of infertile men. This was just one research paper where they quantified that. And other studies support that frequency. And then this is just reiteration that the incidence of chromosomal abnormalities, like in this study, supported what we know. It's way higher in infertile men than it is in the general population. And then this goes into each of the different microdeletions. So it's about 1% of azoospermic men are going to be found to have the AZFA microdeletion. Again, no sperm, I'm like hammering you with this, no sperm will be there on the testicular extraction, and so don't do it. B and then BC, that's going to be 1 to 3% of men with azoospermia, so a little bit more common. Again, very little chance of retrieval. And then for C, this would be the most common, about 1 in 4,000. Of these men, and then 13% are going to be azoospermic, 6% severe oligo, and then again they're just having impaired spermatogenesis. So the quality when you find a sperm is normal. This is again just talking about sort of the prognosis. All right, so moving on to one of our other buckets, obstructive. So this is like 100% going to be on the test. So congenital bilateral absence of vas deferens, CBAVD, and the gene review, they call it CAVD, because you can't have unilateral also. That's going to be 6% of your obstructive azoospermic males are going to be found to have this, and it's about 1% of your infertile males. Again, it's caused by homozygous or compound heterozygous mutations in the CFTR on chromosome 7q31. The congenital bilateral absence of the vas is found in more than 25% of men who have the obstructive azoospermia, and it's going to be complete or partial defect of the Wolffian duct, okay, which includes the vas. In 80% of men who are identified to have this, which would be like on physical exam, right, which typically is not me, it's typically a urologist who would be doing that exam, the mutations are going to be identified in the CFTR gene. This abnormality should be suspected in anybody who has severe oligo or azoospermia, if they have a low volume of ejaculated semen, and specifically if they have low fructose, is typically what we say. But, you know, it can be low pH, elevated citric acid, elevated acid phosphatase, low fructose, failure to coagulate. All of this is telling us that certain parts are not putting in their component into the semen. But it's the seminal vesicles are responsible for the fructose, and that's why we always think about the low fructose. The evidence of abnormalities of the seminal vesicle or the vas could be found on ultrasound in addition to physical exam. And then we just said that. And then you're going to be obviously suspecting this if you have a guy who's found to have biallelic CAVD causing CFTR variants. So you could have a guy who comes in with his wife for infertility testing, and they decide to undergo preconception genetic carrier screening, hasn't had a semen analysis yet, and you find out that he actually has like mild CF. There's a question. That's exciting. Can you unmute and ask? I think there's also, let's see. How do I do that? I don't know how to do it. All right. Karen, are you able to unmute and ask? No? Okay. Maybe she accidentally raised her hand. Okay.
Sorry, so you were saying what will be the example for this situation?
Oh, but you could have a couple come in who gets preconception carrier screening, which is all the autosomal, with like 176 genes, looking at the autosomal recessive disorders, which includes cystic fibrosis, and he could be found to have 2 CFTR variants, and you realize, oh, we haven't done your semen analysis yet, but you might have, CAVD, and that could be the cause of your infertility. Does that make sense? I was just trying to think of an example of when you would have that information before you knew something else. You know what I mean? So that could be the way. If someone sent like the myriad screen. Okay. So again, generally identified during your evaluation for infertility. It could be incidental at time of surgery. It's going to account for, like we said, 1 to 2% of male infertility. You could have hypoplasia or aplasia of the vas, seminal vesicles. It can be bilateral. It can be unilateral. But like we said, you're going to have normal testicular development and function, and spermatogenesis is normal, right? It's just an obstruction. Thinking about the lungs getting mucked up, the pipes are mucked, okay? But the testis is normal. Cool? So greater than 95% of males with CF are going to be infertile due to this. I mean, virtually all guys with CF are going to have CVAVD. And you could have men without clinically apparent lung or GI features of CF that have sort of mild CF that is only manifesting as CVAVD. And then this is probably going to be on the exam, talking about the intron 8 CFTR variants, and how the 5T allele can reduce the proportion of your functional CFTR protein, and this occurs in about 5% of the population and can be associated with CVAVD. And so if you have 5T in trans with the R117H, that you can have CVAVD, and this is CVAVD, and that is the most common genotype. If 5T is in cis with the R117H and another CF mutation, you can have a variable phenotype. And then 20% of patients who have the clinically evident CVAVD, and 8% of patients who have the unilateral form may not have their mutations found. And in that case, you might want to consider testing for this other gene. I think I've got that on them. Yeah. So there's this X-linked version that looks clinically identical to the CFTR genotype that's caused by this CDGRG2. I don't think they would put that on the exam, but I think for clinical purposes, it's good to know. And like I said, it is X-linked XP2 too. Yep.
Some cases where there's heterozygous, like if they're in infernal men, is there or kind of vaguely remember some discussion of one of them being heterozygous variants, or you haven't seen that?
You mean being a carrier?
There's some other variants.
Well, I think that what's hard is that it's like assumed that they have biallelic mutations, and you may not find it in the second allele. That's actually, I wish Dr. Hart was here, because I feel like she'd be able to clarify that for us.
I just remember something vaguely about that.
But I'm pretty sure that's what's assumed, that there is another pathogenic variant, but that for whatever reason the testing was negative, but it's there, you just couldn't see it.
Maybe also when I learned about this was like 15 years ago when like the panels weren't so comprehensive.
Oh,
That's
sure.
What I'm remembering.
Right, that you'd see like Delta 508 and you wouldn't see the second hit, but until you assumed it wasn't there yet. So we talked about this again, that with what I do in clinic, with ART, anisperm aspiration or extraction, and IVF, that we'd be able to, these guys would be able to have kids. And obviously if they use donor sperm, they could have kids. And then this is talking about like when to consider testing, which I think could be on the test. So obviously anyone related to the first, any first degree relative is going to potentially need to be tested for if the program has PAVD. Sorry, that's the same point again. I was stayed up very late doing these slides. Sorry.
I think that's what my question was, right?
Which one?
Then with PAVD, they have only one identified PSTR variant. Okay. Complicated with testing.
Yeah.
Okay. I remember.
Yeah. And this is from Gene Reviews, these bullet points. And then, of course, the risk to the relatives of program is going to depend on the parental genotypes. And without the parental genotypes, we can't necessarily predict what it's going to be. And there is a chart, I didn't include it, there is a chart in the Gene Reviews that goes through some different genotypes and what the phenotype can be. But like I said, I try to keep it more clear because I think this is the most high yield right here. 5T and trans with R177H, CD, AVD. But like I said, there's a whole chart in Gene Reviews that we should probably look at. And then this is also from Gene Reviews. It talks about, your differential diagnosis with the obstructive azoospermia. These are the two syndromes that are mentioned. Young, which again is a progressive obstruction, same kind of thing, mucked up pipes, and chronic sinopulmonary infections is similar to CF. They do have malformations of the vas or the epididymis. But it's going to be someone who doesn't have pathogenic variants in CFTR. And then this hereditary urogenital dysplasia, autosomal dominant, variable expressivity, reduced penetrance. Females can have some anomalies too, and it can be unilateral or bilateral abstinence. So just other things to keep in mind. But for the test, I think they're going to ask us about CFTR. And then just sort of like broad strokes, because there's not enough time in an hour to talk about all the different causes. We've said that you can have androgen receptor defects, so you could end up with androgen insensitivity syndromes like forms of DSD. That's that. Hypospadias isn't going to be a direct cause of male infertility, but could be related to some other, issue going on. Cryptorchidism, could affect the if it's part of a syndrome, could affect the function of the testicular tissue and spermatogenesis. Obviously, if they have any sort of deficiency in their ability to make testosterone or something like that, that could, impair the system, especially during embryology and development. Kallman syndrome we talked about, GnRH deficiency, related to Kallman. There's also this DAX1 issue, so you can have DAX1 duplications, you can have DAX1 mutations. These are, the DAX1 duplication is also related to gonadal dysgenesis. And then the DAX1 mutations, you actually end up with this adrenal hypoplasia congenita, and they can end up with hypo. So two different mechanisms, same gene, one in excess and one reduced. And then obviously you can have disorders of sperm function, where like the morphology of the sperm is impaired, and so you can't have fertilization. This was the same slide again. So just to go over this one more time, and I really don't think that they're going to give us like endocrine markers and then ask us to work backwards, but if they did, so if you have, you got to think about brain, and then testes, and sort of how they're talking to each other. The way I always explain to patients is the brain has to talk to the gonad, right? So I'm not usually talking about the ovary, but it works the same for the testes. So the brain is going to use GnRH to talk to the pituitary. The pituitary is going to send down the gonadotropin, and the gonadotropin is what tells the testis or ovary to do its job. If you have an intact hypothalamus and pituitary, and you're sending down a normal amount of FSH, you're going to have normal testicular volume, you're going to have normal testosterone, and then the testosterone is what feeds back to the brain and tells the brain, we're good, the system's working. If you have an interruption in the GnRH, then you're going to have, it's not on here, but you're going to have the low FSH. Low FSH means that the brain's not talking to the testes is being starved, right? So it's going to be small, firm, rubbery, and you're going to have low testosterone and lack of feedback, okay? If you have, like Kalman, sorry, that was Kalman. If you have primary testicular failure, like Klinefelter, you're going to have the small testes not producing testosterone, the negative feedback is not there, and the brain is going to scream at the testes trying to get them to work, and that's the high FSH. So those are the three sort of ones, okay? So this is more about Kalman, and then these are all the different genes, and to be honest, we have, in REI, for our exams, we have to know, like, all of these genes, and I don't know which ones we need to know for, like, from a genetic standpoint. I don't know if y'all have any input on that. Okay. Yeah, I mean, the big ones are obviously GnRH, the kispeptin, the KISS one, the CHD7 obviously is related to charge, and so that could be high yield. We also typically know FGFR and PROC2 and PROC receptor 2. These other ones are a little more obscure. And then also to notice that there are X-linked forms, recessive forms, there's dominant forms. So it's kind of all over the place. And then, like I said, you can have normal sense of smell and get on the side of it, or you can have anosmia, which is classically going to be described as hypo with anosmia is common. And again, hypo is hypogonadotropic, hypogonadism. So the hypogonadotropic is the brain part, gonad is the testis or ovary part, right? And then again, this was the, to me, like a really good broad strokes overview of what the buckets of sort of the male infertility, then what the genetic thing maybe that we're thinking about, what the target is, and then how we might do tests. Again, I would sort of, like, from an academic standpoint, great that these things exist down here, but I would stop after the Kalman syndrome here, and the most high yield are these three at the top. And then these are just the references I used to put this together. You're welcome. Yay.